The multiple birth accounts for 2 to 3% of live birth, and the incidence increasing due to the assisted conduction and increasing maternal age. The background, the perinatal mortality and morbidity is higher with multiple pregnancies than singletons. Therefore, these pregnancies requires additional support. The risk of pregnancy, as all we know, that complication is much more higher than in monochorionic pregnancy than dichorionic pregnancies. The most accurate time for determination of the chorionicity in twin pregnancy is the first trimester, especially between 11 and 13 weeks. Why? Because this will change your protocol for scanning in dichorionic twin pregnancy. In dichorionic twin pregnancy, you will starting from 16 weeks and every 4 weeks. By a monochorionic pregnancy, you will start every from 12 to 16 weeks and then every 2. Determination of chorionicity in dichorionic pregnancy, there is triangular, we all know the lambda sign, while in monochorionic pregnancy, the T sign, which is specific for the monochorionic pregnancy. So as we said, the protocol for ultrasound will depend on the chorionicity. In monochorionic pregnancy, in each scan, we will assess the fetal growth, the amniotic fluid, the Doppler, and in monochorionic twins, the middle cerebral artery peak systolic velocity should be detected to detect a twin anemia polycythemia sequence or TAP sequence. The monochorionic diamniotic twin pregnancy, as we said, scan will start at 12 and 16 weeks and then will every 2 weeks until delivery, and the review will be every 1 week if there is any complication like discordance in the fetal size, that 15%, or the discordance in the amniotic fluid or any abnormal Doppler, and if no complication, they consider delivery at 36 weeks. In monochorionic monoamniotic, the same protocol for scan will start from 12 and 16 weeks and every 2 weeks, and we will change the protocol every 1 week if any complication were present. So what the specific complication for monochorionic twin pregnancies? First, the most famous twin-twin transfusion syndrome, which is the prevalence of 10 to 15% of monochorionic twin pregnancies. By ultrasound diagnosis, there is an imbalance in the net flow of blood across the placental vascular communication from one fetus, the donor, to the other fetus, the recipient. So in ultrasound, early detection of twin-twin transfusion from 11 to 14 weeks by early detection is suspected if there is discordance in the size of the amniotic fluid sacs, or discordance in the fetal nuchal translucency, or absent change in the Doppler of the ductus venosus in the fetus with higher NT. After 15 weeks, the oligohydramnios and the polyhydramnios is in the sac of periodic by we can detect early twin-twin transfusion syndrome. We classify the twin-twin transfusion syndrome by continuous staging into 4 stages according to the finding in diastolic flow, the umbilical and ductus venosus. Stage 1, the donor bladder visible in diastolic flow, positive in both vessels in both fetuses. Stage 2, donor bladder is not visible with a normal Doppler. Stage 3, in diastolic flow is absent or reversed in either vessel in either fetuses. And then stage 4, the presence of ascites or hydrops in either fetuses, usually the recipient. How we will follow up the scans for the twin-twin transfusion, detailed ultrasound examination. The ultrasound scan will be every 1 week for fetal growth, amniotic fluid volume, and the Doppler for pulsatility index, the umbilical and middle cerebral and ductus venosus of both fetuses. The management in discordant in amniotic fluid, just discordance in amniotic fluid, polyhydramnios, oligohydramnios, their overall survival is 95%. Progression to twin-twin transfusion is 15%. The ultrasound scan will be every 1 to 2 weeks. But in stage 1, the survival rate, the most important endoscopic laser ablation of the communicating vessels by the laser photoscopy, the survival rate will be overall 85%. At least one twin will survive 19%. The progression to stage 2 and stage 4 will be 20%. In stage 2 and stage 4, if the case is the gestational age is less than 28 weeks, the best management is endoscopic laser. And if the gestational age is more than 28 weeks, the best option is delivered by cesarean section, and the timing will be depend on the Doppler finding in the umbilical and the ductus venosus of both fetuses. The survival rate in stage 2 overall 75%, at least one twin 85%, but in stage 3 and stage 4, the survivor overall 16 to 70%. The neurodevelopmental impairment in survivors will be in 5 to 10%. Follow-up after laser therapy, ultrasound and Doppler every 1 week until the resolution of signs of twin-twin transfusion and normalization of Doppler finding. Second specific complication for twin-twin transfusion, twin anemia polycythemia sequence. The prevalence if it's spontaneous for 5% or after laser ablation for treatment of twin-twin transfusion from 2 to 10% of monochorionic twin pregnancy. The ultrasound diagnosis, the TAPS or the twin anemia polycythemia sequence occurred due to the slow transfusion of blood from the donor to the recipient through few very small arteriovenous vascular anastomosis, leading to highly discordant hemoglobin level between both fetuses. This table showing us the difference between both fetuses, the anemia and the polycythemic fetus in size and the amniotic fluid, no difference, but in the placenta will be the thick and hyperechogenic. In the anemic fetus, but the polycythemia will be thin and translucent. The middle cerebral artery peak systolic velocity will be more than 1.5 for a multiple of median, but in polycystic fetus will be less than 1 multiple of median. In organ changes, the dilated heart in the anemic fetus, the tricuspid regurgitation and ascites, but in polycythemic fetus, the liver status K pattern. The management of twin anemia polycythemia or TAP sequence, the management if the gestational age is less than 26 weeks, the endoscopic laser ablation following up after every 1 week to monitor the fetal growth and brain anatomy. If the gestational age is from 26 to 30 weeks, the intrauterine blood transfusion to the anemic and exchange transfusion with Hartmann solution for the polycythemic twin pregnancy, and the follow-up will be every 2 to 3 days. If the gestational age for more than 30 weeks, the delivery by cesarean section. Twin reverse arterial perfusion sequence, one normal fetus, bump twin, and the other with no cardiac activity or acardiac twin, variable degrees. The ultrasound, the color Doppler for recipient twin will be reversed flow from the umbilical arterial anastomosis and venous return to the bump twin via the veno-venous anastomosis. The ultrasound diagnosis of the trap, the size of the acardiac mass is prognostic value for the survival of the bump twin. About 50% of the bump twin die before or after birth from the congestive heart failure. The management occlusion of the blood flow from the acardiac twin by several methods, especially the ablation of the umbilical cord vessel by laser or diathermy, or coagulation of the placental anastomosis by laser. The preferred management is the ultrasound guided laser coagulation or radiofrequency of the umbilical cord vessels within the abdomen of the acardiac twin at 11 to 13 weeks. The survival will be from 70 to 75%. The follow-up, if we do intrauterine intervention, the scan will be every 1 week to confirm that the bump twin is alive. And if there is no intrauterine intervention, the scan will be every 2 to 3 weeks to monitor the growth of the acardiac twin, heart function of the bump twin, and the amniotic fluid volume. Selective fetal growth restriction, the prevalence is from 10 to 15% of the monochorionic twin. The ultrasound diagnosis, the estimated fetal weight is less than a 5th percentile in the small fetus and more than 25% discordance between the two fetuses. The amniotic fluid in the small fetus is reduced and in the other fetus is normal. The condition is divided into 3 types. Type 1 with end-diastolic flow is positive. Type 2 is end-diastolic flow absent or reversed. But type 3 will be changing or cyclic change in end-diastolic from positive to absent or reversed. If there is the presence of more than 25% estimated fetal weight discordance between the two fetuses and there is a polyhydramnios in the sac of the bigger twin, we will have the condition of selective fetal growth restriction with superimposed twin-twin transfusion syndrome. This is a video showing the selective fetal growth restriction. Management of selective fetal growth restriction, type 1 and type 2 without twin-twin transfusion, endoscopic laser ablation. Type 1 without twin-twin transfusion, expectant management for close monitoring to define the best time for delivery according to the Doppler finding. Type 2 without twin-twin transfusion, if the gestational age is more than 26 weeks, close monitoring delivery will depend on the Doppler finding for ductus venosus and diastolic flow become negative or reversed. The type 2 without twin-twin transfusion, if the gestational age is less than 26 weeks, the endoscopic laser ablation of the communicating placental vessels. The management of survival, the survival of the big baby is 70%, and of the small baby depends on the ductus venosus and diastolic flow. In the third type, or type 3, which is changing Doppler, the best management is close monitoring and delivery of the on the basis of the ductus venosus and diastolic flow in the small fetuses. Lastly, the conjoined twins. The conjoined twin represents 1% of the monochorionic twin resulting from splitting of the embryonic mass after day 12 of fertilization. According to the site of fusion, the classified according to the site of fusion, the most type is the Suraco-Vegas, 75%. On the thorax and the abdomen, often conjoined heart, liver, and intestine, biovagus, ischiovagus, craniovagus, and omphalovagus. The management of conjoined twin, pregnancy termination, and if the pregnancy continues, delivery should be by cesarean section in the center with expertise in the management of such pregnancies. Thank you.